Thank you. So welcome back to our late night retina sessions. We are coming back again with after a very long time, and we have a couple of very good cases this time around. We'll be emphasizing this time with macular neovascularization, and this is one of the episodes for the topic of macular neovascularization. So for the moderator today, we have Dr. Bhavik Panchal. He's the vitreoretina and uveitis consultant at LVPI Vishakhapatnam, and he's also the head of the campus there. Over to you, Dr. Bhavik.
So thank you, Dr. Avnish. The late night retina wouldn't have happened if not for Dr. Avnish and a lot of other co-consultants here or colleagues here. So to begin with, we are going to start with an interesting session on inflammatory CNVMs and angiostreak CNVMs. We have our panelists today, Dr. Chitranjan. So Dr. Chitranjan Mishra, he is the head of the department, Vitreoretina and senior VR consultant at Trilochan Netralaya in Sambalpur in Odisha. Joining him is Dr. Apurva Ayachit. She's a VR consultant at the M.M. Joshi Eye Institute in Hubli. And to help them around and to also give his inputs is Dr. Abhishek Anand. He's an assistant professor at the RIO Patnaya. So we have interesting cases. We'll begin with Dr. Bhavani, who is a VR consultant at Arvind Eye Hospital, Madurai, and she'll be presenting her first case. So over to you, Dr. Bhavani. You can share your screen. Also, by the time Dr. Bhavani starts and all, any comments or questions, it'll be good that the participants can write it down in the chat. We'll take them up. We started on time and we will end on time as well.
Good evening all. Am I audible and am I?
Yes, Dr. Bhavani, we can hear you. Yeah. Dr. Bhavani, your voice is breaking.
Bhavani from Arvind Eye Hospital, Madurai, and I'm here to present a case on inflammatory CNVM. Is it clear now, sir?
Yeah, much better. Please continue.
Is it clear now, sir?
Yes, please continue.
The topic I'm presenting today will be inflammatory CNVM and white dot syndromes. At the outset, I would like to express my gratitude to the head of my department, Dr. Naresh Babu, sir, for his support and guidance, and also two other consultants, Dr. Karthikeyan or Dr. Radhika, who helped me in the treatment of this patient. The patient was a 28-year-old female patient who presented with the complaints of scotoma in her left eye in the supratemporal area of central visual field for 2 weeks duration. And she said it was of sudden onset. She gave a history of redness in her left eye 1 month before her presentation, and she was treated elsewhere with topical NSAIDs. She gave no history of any fever or any viral prodromal illness, and she was nil systemic. Coming to the examination, both her right eye and left eye had a best corrected visual acuity of 6/6, and she had a refractive error of -4.5 diopters in her right eye. She had a refractive error of -4.5 diopters in her right eye and -5 diopters in her left eye. And her intraocular pressure was within normal limits in both the eyes, and her anterior segment examination was also within normal limits in both the eyes. Coming to the fundus examination, her right eye examination was within normal limits, whereas her left eye, the fundus examination revealed multiple hypopigmented subretinal lesions seen in the mid-peripheral fundus in 3 quadrants, superior, temporal, and in the inferior areas. Whereas the nasal side, we couldn't make out any hypopigmented lesions. And the cup disc ratio in both the eyes was 0.7. So the patient was initially sent for a glaucoma evaluation, and the HFA 30-2 done in the glaucoma department revealed exotomata in her left eye. And OCT showed normal peripapillary RNFL thickness. Patient underwent UVR blood investigations and blood pressure examination, both of which were within normal limits. Topical NSAIDs were prescribed, and patient was advised to review with FFA and OCT both eye macula. 4 days later, patient presented for her FFA, and at that time, the fundus examination remained the same. Fundus fluorescent angiography revealed a hyperfluorescent lesion infranasal to the fovea, and it remained the same throughout all the phases without any leakage. Her OCT examination of the right eye was within normal limits, and the OCT examination of the left eye through the fovea showed a small area of hyporeflectivity in the ISOS seen nasal to the fovea. And there was also an area of RP elevation and irregularity infranasal to the fovea, and closer to it, there was a decrease in the ISOS junction hyperreflectivity. PRAN2 was negative for the patient, and the provisional diagnosis of multiple evanescent white dot syndrome was made. Patient was started on tablet prednisolone 40 mg for 1 week, which was followed by a weekly tapering dosage. Patient was advised to review after 15 days. 15 days later, when the patient presented to us, her fundus examination showed a decrease in the number of hypopigmented lesions subretinally compared to the previous visit, but still it remained. Patient said she was symptomatically better, so she was advised to continue with her oral steroids as per the tapering dosage and review after 15 days. 15 days later, now the fourth visit when the patient presented to us, most of the lesions had disappeared except for very few ones seen in the temporal quadrant. OCT during this visit through the fovea, it showed a normal foveal contour, and the area of ISOS hyporeflectivity, which was noted in the previous visits, has restored back to normalcy in the left eye. But the area of RP elevation and irregularity, which was seen infranasal to the fovea, it persisted. But till this visit, we did not see any subretinal fluid or intraretinal fluid around this lesion in the OCT. So the patient was advised to stop her oral steroids and advised to continue topical NSAIDs and review with the ICGA. 5 days later, patient presented for her ICGA evaluation. ICGA of her left eye showed a few hypocynosal lesions nasal to the fovea as well as temporal to the fovea. And these hypocynosal lesions persisted through all the phases of ICGA. And in addition, in this image, we can also see that there were hypocynosal lesions inferior to the disc as well as superior to the disc. So these are the images through the various phases of ICGA. The hypocynosis remained the same through all these phases. So patient was advised to continue topical NSAIDs and review to us after 1 month. 1 month later, when the patient presented, there was she said complaints of increase in the number and the size of scotoma in her left eye in her central visual field. But her best corrected visual acuity remained the same as 6.6. OCT during this visit showed an RP irregularity with an elevation along with subretinal fluid nasal to the fovea. Autofluorescence was done during this visit. Right eye autofluorescence was within normal limits, but in the left eye, we could see hypoautofluorescent lesions below the disc and above the disc, and also a hypoautofluorescent lesion surrounded by margin of hyperautofluorescence just infranasal to the fovea. So this was suggestive of an active inflammation. OCTA was done during this visit, which showed medusa-shaped choroidal neovascular membrane in the OCTA. So the patient was advised left eye intravitreal bevacizumab injection, and she was also started on tablet prednisolone 30 mg for 15 days, but this time in a 2-weekly tapering dosage gradually. 1 month later, patient, when she presented for her post-injection follow-up, patient was symptomatically better, and her best corrected visual acuity remained as 6.6 in both the eyes. OCT of her left eye during this visit showed the resolution of SRF, but there was a RP irregularity still persistent with hyporeflectivity nasal to the fovea in the ISOS. And infranasal to the fovea, that RP elevation, it still persisted. And the autofluorescence during this visit in the right eye was within normal limits, and in the left eye, the hypoautofluorescence was there, but the margin of hyperautofluorescence, which was seen in the lesion in the previous visit, had reduced during this visit. Patient was advised to continue her oral steroids and then stop it over the next 2 weeks as per her schedule, and then review after 1 month. Then the patient was lost for follow-up for the next 6 months. Patient presented to us with complaints of new onset scotoma in her left eye of 10 days duration after 6 months. And this time as well, her best corrected visual acuity remained 6.6 in both the eyes. Anterior-segment examination was within normal limits, and her right eye fundus examination was also within normal limits. Fundus examination of the left eye showed parafoveal scars nasal to her fovea with macular edema. And OCT during this visit showed a new lesion, but this time temporal to her fovea with overlying intraretinal fluid. And the previous lesion which we had seen 6 months before, that RP elevation was still persistent nasal to the fovea. And the OCTA, which was done during this visit, revealed a choroidal neovascular membrane corresponding to the area of lesion which was seen clinically. So patient was advised intravitreal bevacizumab, and it was administered to her on 2nd of this month. 2nd of last month, but patient is yet to turn for follow-up following this injection. Thank you. Now I open this case for discussion for the panelists.
Thank you, Dr. Bhavani, for completing your talk on time. So with this, I would like to invite in Dr. Apurva and Dr. Chitranjan first. So the diagnosis is straightforward here about it's a CNVM. It's an extra foveal choroidal neovascularization, and the octa showing a beautiful net there. The question which I want to ask is that to our panelist, first of all, what will be the etiology for this choroidal neovascular membrane? Okay, because a lot of differentials which come to my mind. Okay, be it mutes, can it be an inflammatory without an idiopathic? I mean to say, let us go ahead, or it can be just some inflammatory pathology, which we still need to look forward and dig deep into it. Dr.
Yeah, thanks, Bhav. So I beg to differ from the diagnosis of mutes because mutes is essentially transitory. It is not really classically known to recur. So since we are talking about choriocapillaritis, I hope my screen is visible.
Yes.
Yes,
Yeah.
yes.
So, yeah, choriocapillaritis is not restricted to mutes. Depending on the degree of choriocapillaritis, all of these come under inflammatory choriocapularopathies. So that includes mutes, APMPP, PIC, multifocal choroiditis, and serpiginous choroiditis. So I just want to bring to your attention this very simple and elegant diagram. This is basically choriocapillaritis, where there is non-perfusion of the choriocapillaris, and depending on the level of non-perfusion, as in if it is just the ends of the choriocapillaris, it is mutes. If it is involving the precapillary arterioles as well, then it becomes a little more severe form of choriocapillaritis, that is APMPP. And if it involves the larger arterioles, then it is the more severe form, which is serpiginous. So it is basically a spectrum, and we should move away from clubbing all these incorrectly into white dot syndromes, because as we know now, based on ICGA, we divide all of these into choriocappillaropathies and stromal choroiditis. So choriocappillaropathies includes mutes, APMPP, PIC. So now coming to my diagnosis, I think mutes, there are some problems I have with the presentation of this patient. So first, I think an AF at presentation and an ICGA at presentation would have kind of captured a lot of baseline data of the imaging in this patient. Also, visual field was done in this patient where a mutes would have shown a blind spot enlargement for sure. And an AF would have shown a peripapillary hypo-AF, which would have gotten better in the subsequent follow-ups. So the fact that this patient had sequelae of old choroiditis lesions in the form of pigmentation, hypopigmentation, that points towards a diagnosis of punctate inner choroidopathy. It's a spectrum of punctate inner choroidopathy versus multifocal choroiditis with panuveitis. So although it used to be called MCP, now it's called an MFC, a multifocal choroiditis. So considering that the disease kept recurring, the CNVMs were migratory in the sense that there were new CNVMs that were coming in different locations, shows that this was a choriocappillaropathy involving a large area, and the lesions kept returning in crops. So I would completely actually disagree from the diagnosis of mutes. Mutes wouldn't recur in such a fashion. And coming to choriocapillaritis, that is including a large spectrum, and it is not restricted to mutes.
Yeah. So thank you, Dr. Apurva. Before going to Dr. Chitranjan to have his point of view, That was also one of the differential diagnoses. If you look at the patient's profile, young female, moderately myopic, which fits into the profile of MFC with PIC, and the AF clearly explains that. Okay, so that is one of the definitely the top differential diagnosis here. When you talk about mutes, when you said about symptoms like signs like enlarged blind spot, and also patients having loss of foveal ellipsoid zone loss of the fovea, which happens in such individuals, and the complaints of scotomas. They're very typical of, or rather, are features of typical mutes. But we also have features of atypical mutes where the typical white dots are absent. So let us take a look on the counterpart from Dr. Chitranjan, what he has to say.
So thank you, Dr. Bhavik and Dr. Apurva. It's nice to see the documentation Bhavani has done. So at least we unanimously that this is a choriocapillaritis. The image that Apurva has shown, that is a nice article where it is describing the stromal choroiditis and choriocapillaritis very nicely. And the typical features of mutes, if we can divide into FFA, ICG, and fundus autofluorescence. In FFA, we get hyperfluorescence. I'm not talking about the CNVM, the lesions of the mutes, hyperfluorescence. ICGA, we get the hypofluorescence lesions or cyanosense. There is a debate, but hypofluorescence, let's tell it, ICGA. And autofluorescence, we get a hyperautofluorescence kind of picture. Out of these three, ICGA is more important or more characteristic, where in Bhavani's picture, what she showed, it is showing hypofluorescent with hazy margins, unlike the stromal choroiditis where you get hypofluorescent dark dots, HDDs, that the same paper where Apurva has shown. So in this picture, ICG is characteristic of mutes, and as Dr. Bhavik told, we have the other differential diagnosis, that is PIC, PIC. Apurva also told PIC. But clinically, if we see young male myope, young female and myope, that goes for the kind of both, in fact, mutes and PIC, both. So we can keep these two diagnoses as our differential diagnosis. But mutes does not always a benign disease, unlike what is the traditional thought. What Bhavani has shown, there are case reports which have shown that CNVM can occur in mutes. In fact, CNVM can precipitate happening of mutes, just like any influenza vaccine or any other stress can, it's idiopathic. It can precede the occurrence of mutes. Similarly, kind of CNVM, pro-inflammatory state, and that can cause mutes. So mutes and CNVM can coexist. This is a rare finding, what Bhavani has told. So I do agree that PIC and mutes both can be differential diagnosis, and it's basically in the broad term, it is choriocapillaritis. We can tell it as choriocapillaritis.
Okay, thank you, Dr. Chindrajan. At this point in time, I'd like to bring in Dr. Abhishek as well. So what you also mentioned is another important diagnosis, okay, where you have one white dot syndrome interspersed with another white dot syndrome. So sometimes we come across patients with mutes and APMPP presenting together, mutes or MFC presenting together. So I want to bring in Dr. Abhishek. Do you have any other thoughts about differentials? And I want to add one question to you.
I think I completely agree with Apurva, but then there is a transition in which we see that, you know, there are papers which have already discussed that mutes can be a presentation of post-PIC, or they can coexist. So, and it's not typical, you know, the typical mutes like foveal granularity is missing. The wreath-like pattern on FFA is missing in mutes. So it's a transient type of picture in which the CNVM is happening as well as the mutes is happening. But then it is post some choriocapillaritis, most probably PIC. So it's a transient. And both of these, the driving factor is inflammatory something, this inflammatory pathology, and this is presenting a picture in which there is a CNVM as well as mutes-like picture, something like that. I feel that.
So I hope, Dr. Abhishek, you're not driving and speaking at the same time.
No.
Yeah. So
am I not audible?
No, you're audible very clearly.
Audible,
so
and
I want to stay on you in terms of you. I want to ask you that what are the different etiologies you come across where you have cases of inflammatory CNVM?
So if you talk about inflammatory CNVMs, I think mutes with CNVM is very rarely reported. It's there, but it's very rare.
Correct.
So most common CNVMs, if we are talking about post-inflammatory PIC and MFC, And then we have other spectrums of which can all present, like APP can present serpiginous, post-serpiginous, or post any infectious healed choroiditis. They all can present with CNVM, but mutes would come, very low in that category. That post-mutes CNVM, it's very less, very rare.
Okay, so thank you, Dr. Abhishek. Before moving on to the treatment aspect of it, which, okay, we all know all CNVMs you're going to treat with anti-VEGFs. There's certain other aspects to it as well. Before that, Apurva, any other common etiologies for inflammatory CNVMs you want to add to the group? Because we have a lot of listeners here and viewers who want to know about different etiologies for choroidal neovascularization that is inflammatory in origin.
Absolutely.
Most common in India, what we see.
Yeah, absolutely. So when we have tubercular choroiditis, for example, and as a sequelae of healing and scarring, definitely you can have secondary CNVMs. It is not clear whether these inflammatory CNVMs are called that because they occur in conjunction with the active inflammatory phase, but it is definitely a sequelae of post-inflammation in tuberculosis, in sarcoidosis. Of course, toxo also can cause secondary CNVMs. There is an entity called punctate outer retinal toxoplasmosis, which are prone for CNVMs. So inflammatory CNVMs have very unique features in the sense that they occur commonly secondary to the known infectious uveitic entities. Also, they have some typical signs like having a pitchfork sign, like the Shrem is in a pitchfork manner, like they have finger-like projections into the outer retina. So that is something we see in many times in inflammatory CNVMs. And of course, they have different treatment modalities. In TB, triple therapy has been described where you give an anti-VEGF also and local steroid, ATT, as well as systemic steroid. So we look
part,
for, sure.
We'll get on the other participants. So it's like as Dr. Apurva mentioned, it's important to differentiate between an infectious cause, like she brought in toxoplasmosis, tuberculosis. On the other hand, we have the inflammatory causes as well, like sarcoidosis, for example. Okay, that is another important cause for peripapillary CNVMs. Again, there are inflammatory CNVMs in origin. And so sometimes we see that when we are treating these patients and patient develops CNV, and it has happened that it has been reported as well. These patients may not opt for an injection since you're already treating the uveitis, especially with steroids. So when the patient is on steroids, we see that occasionally the CNVA may also resolve. So here comes my second question here. What is the role of steroids or oral steroids, intravitreal steroid, or steroids in any form in the treatment of inflammatory CNVs? This is to Dr. Chitranjan first and then Dr. Abhishek.
So, Dr. Vavik, before answering the role of steroid, I just want to add another etiology, that is POHS. Yeah. Fortunately, that is very, very rare in India. Presumed ocular histoplasmosis syndrome. That is also described one of the etiologies of inflammatory CNVM. In fact, the surgical part we will be discussing over here. In POHS, the subretinal membrane that happens for the CNVM, they have done surgery and they have published, though it's an old one. So now coming to the steroids, it's whatever literature I could see, it is systemic steroids basically they are telling. So the addition of systemic steroids with intravitreal injections, okay, like anti-VEGFs. Mostly now we have moved towards anti-VEGFs. So the combination of both of these actually works better. And we must admit that there is no comparative trial to tell which one is kind of working best and which is against that. But it is always mentioned like that. And intravitreal injections of combination sometimes we give, though we give either intravitreal steroids or intravitreal anti-VEGFs. Some rare cases where we combine both of these, we would have seen some of our colleagues. These are inflammatory CNVMs are one of the indications where we tend to give both simultaneously, like intravitreal steroids and intravitreal anti-VEGFs. These are about the steroids.
Okay, Dr. Abhishek, how would you go about management of these patients? We know anti-VEGF are the drug of choice, but would you consider loading dose for such individuals or directly a PRN basis? So in origin most of the time, so the visual acuity remains good.
So
if there is not a major subretinal hemorrhage. Yeah, in the fovea. Go ahead, please.
So there are some things which we have to admit is that most of them respond better than our classical wet ARMD, right? These CNVMs respond way better. And there have been a few studies which have compared the PRN regimen with a loading dose regimen. What they found was that the PRN regimen works equally good as the loading regimen. So you decrease your number of injections with the PRN regimen, and they do good actually with along. If you do the loading dose, they're comparative, always comparative like that. So in my practice, I would prefer a PRN regimen rather than going for a loading regimen. And regarding that, uh, the recurrence in these cases is around 20 to 25%. So we have to look closely how they are recurring. And unlike wet AMD, you don't require a prolonged treatment, right? That the patient will require lifelong treatment. So we have to also take into that. And as Chitranjan has already accessed, that most of these patients, the driving force is the inflammation. So that is the cause of inflammatory CNVM, which is causing the breaks at the Brooks membrane or causing the choriocapillaries to sprout. So we have to control the inflammation along with the intravitreal anti-VEGF. That should be the, and how do we control it is up to the treating individual, right? We can go for systemic management or we can go for local injections for controlling the inflammation. So both of these have to be taken care if you want to decrease the number of injections in the long run. That is my take.
Dr. Bhavani, can you share your screen once and compare the OCT before treatment and after treatment? I want to get attention of a panelist on one important observation here. Can we have both the images on one page, before and after treatment, on one slide rather?
I have them in two different slides only. Is it okay, sir?
Yeah, okay, no problem.
This is the pre-treatment picture.
No, the OCT.
OCT, Bhavani, OCT.
Pre and post injection, right?
Yeah. Okay, the previous one. You can go slow.
Yeah, this was the pre-injection OCT.
Okay, it's from a different level. So what I wanted to show was, yeah, you can go to the last OCT.
Yeah, one second. And this is the post-injection OCT.
Yeah. So if we notice one thing, I don't know if we can compare it or not. If look at the elevation here, okay, about the RP. After the injection, what we see, especially in myopic CNVMs, even inflammatory CNVMs as well, it is a well-defined border or edges of the lesion here. Okay, whereas in a patient who's for whom the CNVM is active, the edge of the lesion is not well defined. It's not smooth. Okay, so sometimes we take this as a marker of improvement because this CNVs don't exude much, unlike in the case of wet AMD or PCV as well. So there is hardly any IRF occasionally present or minimal amount of SRF. So what are your comments about this as a biomarker to understand that, okay, this is a well-defined border after, can this define a treatment response?
You want to specify someone, Bhavi?
Yeah, you can speak. Go ahead, no problem.
Actually, in these cases, I must tell you frankly, this is always the patient's symptoms that drives us to give injection or not. Because if you see like this, there is no SRF actually. There is no biomarker that traditionally we think that is subretinal fluid. So in these cases, if the patient is still symptomatic, we tend to give more injections. However, definitely this biomarker is a sign which tends towards kind of quiescent thing.
Yeah.
But if the patient is not having symptoms additionally, then we tend to kind of observe.
See, if
May I make a comment?
We have a one.
Yes.
Here. I just want to show this. This my cursor can be seen here. The edge is not as smooth as what we have. This is pre and post treatment.
Yes.
Yeah, rather than smooth, Bhavik, I would call it like a well-defined scallop.
Well-defined.
Scalloped lesion. If
Correct.
it is very well defined, it is very well defined and scalloped. with a very well-defined edge, then it is definitely a treatment response. On the other hand, if the margins are very sloping, gradual, there is overlying sponginess of the retina, like you see when the CNV recurs in this case. Intraretinally, where there is sponginess and the slopes are smoother and more gradual, that is when it is active. And it starts getting steeper and scalloped and well-defined. Yes, like you said, it's definitely.
Okay, so thank you to all the panelists. Thank you, Dr. Bhavani, for bringing us such a nice, wonderful case that we could have a detailed discussion. Please stay back.
Can I put one question for the panelists? I mean, just for because we have a lot of viewers, there is one question. Like there are a lot of, not everyone has access to Octa, right? Still, right? Although it is well established. But then sometimes we have CNVM sitting along with an active choroiditis patch or something like that. Then what are your takeaway points that, okay, we are going to treat this with anti-VEGF? I mean, sometimes it becomes very dicey. So there is an active choroiditis patch along with a sitting CNVM component.
Dr. Abhishek, we can discuss this in the chat.
Okay.
We do start on time.
Okay.
Yes. So next we have Dr. Samiksha Agrawal. She's a VR consultant at Krishna Eye Foundation at the Eye Clinic in Prayagraj. So over to Dr. Samiksha. She's going to bring us another interesting case of an angiotic CNV. So we'll have two presentations here. First by Dr. Samiksha, and after that we'll have presentation by Dr. Amit Kumar Deb. I'll introduce him when his turn comes. We can have a discussion in the chat meanwhile, Dr. Abhishek and other panelists.
Yeah, is my screen visible?
Yes, Dr. Samiksha, please go ahead. Welcome.
Yeah, so I'll just start this. There was this 38-year-old female which came with chief complaints of blurring of vision in her right eye since 7 months, which was insidious in onset and gradually progressing, and no significant past history or no systemic history as such, no family history or personal history. On examination, best corrective vision in right eye was counting finger 3 meters, and in left eye it was 6.9. So anterior segment was well within normal limits, and on fundus examination we saw there was presence of subretinal heme, also associated CNVM. And when we look closely, there was this. If you see there you can see all these grayish lines radiating from the optic disc in both the eyes. It was seen suggestive of angioid streaks. We ordered for OCT FF, and on OCT we saw that in right eye there was presence of CNVM with some subretinal fluid and subretinal hyperreflectivity as well. In left eye, as such, there was normal foveal contours. Some RP changes can be seen, and on doing FFA, we see that some early hyperfluorescence with late leakage and increase in hyperfluorescence is seen. Also around the disc, if you see these radiating lines can also be made out, suggestive of all these angioid streaks. So again, in left eye, some hyperfluorescence is seen around the temporal to the disc margin, and on nasally, if you see, there is this hypofluorescent lines radiating from the disc, suggestive of angioid streaks. So so the diagnosis was both eye angioid streaks with right eye secondary CNVM. So we advised for right eye intravitreal anti-VEGF injection, and intravitreal ranibizumab injection was given in the right eye. So on 1 month follow-up, we see that there was the subretinal heme had dislocated temporally, and there was some reduction in CNVM component. In left eye also, you see there is some RP changes. We are not really sure if it had progressed, but the fovea was okay. So yeah, the case is open for discussion.
Thank you, Dr. Samiksha, for such a short and a sweet presentation. Before we open the forum for discussion, we'll go ahead with Dr. Amit Kumar's presentation as well. Again, on a similar topic, but a different case altogether. So in the meanwhile, Dr. Amit shares his slides. Dr. Amit Kumar Dev is an associate professor and a VR surgeon at JIPMER Pondicherry. Dr. Amit?
Yeah, I am just
yeah, welcome, Dr. Amit.
Share my screen. Yeah, thank you. Is my screen visible now?
Yes.
Okay, let's go to the presentation mode. Very good evening to all. At the outset, I'd like to thank the whole team of Late Night Retina Session to provide me this opportunity to speak on this platform. So I'll be again showing one more case of CNBM in Android streaks. So this was a 43-year-old gentleman hailing from Kadlur district, Tamil Nadu, who was a shopkeeper by occupation. He presented with complaints of blurring of vision and distortion of images in his right eye for 10 days. He had no systemic comorbidities at his presentation. So best corrected visual acuity was 6 by 9 in the right eye and 6 by 6 in the left eye. Other intersegment examination was unremarkable in both the eyes. So once we go to the fundus examination, we can see the brownish gray lines concentric to the disc and the radiation from the disc, that is the angioid streaks. Then as we move towards the macula, we can see the subretinal plug with surrounding subretinal fluid and the focus of subretinal bleed here. And temporarily, we can see some pigmentary changes, probably the PUD orange, the classical, which is described uh, in case of pseudoxanthoma elasticum. So in the left eye also, if you can see the angioid streaks here, and also some pigmentary changes temporal to the fovea. The macula appeared relatively normal in this case, although some pigmentary changes are seen, and no evidence of any plaque or CNBM. So on OCT examination, you could see the subretinal fluid in the right eye and the type 2 CNBM, whereas the left eye OCT showed a normal foveal contour. So on systemic examination for the patient, we could see plucked chicken skin appearance on the lateral aspect of his neck, and then this yellowish papules on the back of his neck. And we're suspecting pseudoxanthoma elasticum, as these are the classical lesions seen. So we had referred the patient for cardiology and dermatology opinions. And cardiology evaluation at presentation, there are no cardiovascular abnormalities. So our differential diagnosis at this stage will be the angiostrics, and pseudoxanthoma elasticum was the most probable diagnosis. However, the similar skin lesions and angiostrics can also be seen in Ehlers-Danlos syndrome Paget's disease. And rarely some idiopathic condition also we can see this angiostrics. So the treatment administered to this patient, we had gone ahead with intravitreal brolucizumab. 3 monthly doses we have given. In fact, the last dose was given yesterday. So one thing to note was we had to rule out the inflammatory etiologies before going ahead with the brolucizumab. So, and also we are pretty sure that is the case of pseudoxanthoma elasticum rather than a secondary CNBM from an uveitis condition. So we thought brolucizumab is a relatively safer option and went ahead with that. So as we also had to advise long-term follow-up, as the recurrences are quite common despite several years of inactivity. You can see some recurrences, and also the other eye also we advise for close follow-up, as you can see almost 70% cases can present with bilateral CNBM. So these are the follow-up images after 1 month of the injection. This was at presentation. After the first injection of brolucizumab, we could see the SRF and the interretinal fluid. SRF is reduced substantially, and interretinal fluid also has reduced. And after the second injection, you can see SRF has completely disappeared, and few specks of subretinal interretinal fluids are there. So we went ahead with the third injection as well. So other clinical features which might be present in a case of pseudoxanthoma elasticum and comet tail lesions, which was not seen in our case. And this is a flowchart showing the diagnostic flowchart for a case of pseudoxanthoma elasticum and presenting with the ocular features. So we had angiostrics here along with PUD orange. And then on skin evaluation, if you see the typical lesions as seen in our case, that's a definite case of pseudoxanthoma elasticum. If atypical skin lesions or skin is normal, then we probably get a case of probable PXC. Then we need to do a skin biopsy followed by a gene mutation analysis. These are my references. Thank you.
So thank you, Dr. Amit. Yeah, I would
Thank
like to ask, start with you itself. So
Yes.
what is the frequency of brolucizumab that you use? Since you used a loading dose, 3 loading doses.
Yes.
The frequency.
So I went ahead with monthly, every 4 weeks I have gone ahead. Actually,
fine. Yeah.
sorry, I had gone ahead with every 4 weeks dose, monthly dose, 3 doses.
Okay, since we left our previous discussion on treatment of anti-vegf, I would like to start with the treatment here itself, because this is no-brainer in terms of the diagnosis is quite apparent. Streaks, along with we have a coronary neovascular membrane, which eventually is going to happen in their lifetime, be it associated with trivial trauma, not associated with the trauma. So I will start with Dr. Chitranjan first. Dr. Chitranjan, so there are no trials per se, which is better. What is your approach for a case of CNVM, CNV secondary to angiographic streaks?
So, it's very straightforward, as you have already told. Only the message is that we should be cautious about the systemic findings in these cases. So, coming to the CNVM, the treatment of CNVM is anti-vegf injections. There is no doubt. But the traditional teaching is that if we give anti-vegf injections, we have to give multiple injections. They do not respond very nicely, unlike the myopic CNVMs that they do. On myopic CNVMs, you tend to expect a better outcome or a less number of injections. However, newer anti-VEGFs like what Amit told about brolucizumab, or for that matter, aflibercept, where they do have extended kind of spectrum of action and VEGF A, VEGF B, placental factor, and kind of extended spectrum of action, and 2 month, 3 month, or like kind of more number of months they tend to act. These newer anti-VEGF injections. With these injections, there are reports that we tend to expect a better prognosis. Maybe like the myopic CNVMs, we tend to get a better prognosis. So traditionally, with bevacizumab and all, they tend to recur resistant, but with the newer anti-VEGFs, the prognosis seems to be better.
Okay, thank you. So the point what we learn here is that patients should be counseled for multiple treatment interventions. In the maybe with a few injections it may heal, but there's high chance of recurrence as well. So Dr. Apurva, a question to you in terms of there is a very interesting paper published in AGO in December 2020 about the extent of angiostreaks and correlation with macular degeneration in pseudoxanthoma elasticum. Okay, so my question to is, when I was thinking about it and like what to discuss here, with the streaks, we know they keep on enlarging on elongating as age increases. Do you think as the age increases and the extent of the streaks can give us a guide on the formation of CNVMs or a direction where it's going to occur next?
Absolutely. So, like that particular paper has told, and one more paper has told, the CNVMs and their severity and their association with vision loss depends on the length of the streak, the distance of the streak from the fovea, and the type of streak also, whether it is narrow, broad, diffuse. So since it's a diffuse Brooks membranopathy, if you can call it that, it is not just about the index CNVM. Like the patient, suppose he presents with one CNVM, that is going to be our index CNVM, but that's not the only thing the patient has to worry about for the rest of his life. So like they have to be on the lookout for metamorphopsia, home amslers, and all of that. Now, coming to your question, I think the index CNVM has to be treated early, and with fewer injections, you can get a resolution, especially if treated aggressively initially itself. But there is always a risk of getting future CNVMs at a different location, because it's a diffuse Brooks membrane disease. It's not going to be just that one CNVM and you get away with it. So yeah, the type of the streak, the length of the streak, the distance of the streak from the fovea, all these are prognostic factors for developments of the first and the future CNVs.
Thank you, Dr. Apurva.
Has
Dr.
anybody, I mean, I'm asking Apurva, has anybody
Yeah.
commented, or to you also, because you both through that paper? So has anybody tried to correlate in the quantitative manner regarding the length and the breadth of the streak and the incidence of CNM? I mean, is there any quantitative correlation also has been done?
I'm not aware of per se any quantitative correlation done, but
Because I'm just asking.
yeah. So what they suggested in that paper is that obviously, and this we know that okay, as the patient is going to age, we have to understand that whenever an individual is born with pseudoxanthoma elasticum, does not have angiostreaks at birth, so they are going to start occurring
So
at
it's a
some point
progressive
in time.
thing. No,
Yeah.
I'm asking about the other
The
angiolysis.
earliest case report, which is suggestive of angiostrix noted, is around, I think, 7 years of age, what I remember from memory. Okay. And as the age increases, this angiostrix even increasing in size, or they
Okay.
keep elongating. So my question was that if we see that, okay, they are elongating and they are crossing the fovea or along the fovea, is there a higher chance of them developing CNV? As if what if the elongation stops? Do we that does that mean that, okay, that person will not develop CNV? That's what I'm trying to extrapolate out here. Or think. So the question to you is that actually I forgot
It's
the
like
yeah.
it's like tearing of something. I mean, you don't know till when.
Yeah.
It's like earthquake plates, not tectonic plates. You don't know till when they will separate,
It's a
till where
progressive
they'll
sort of
separate. Will
change.
it stop?
Yeah.
Will it be there? Will it stop? We don't know. A place which is prone for earthquakes will always keep happening.
So,
So
has there been any prophylaxis advised?
I don't think so. We can do some Alexis here per se.
Just
I think
avoid
Amit
trauma.
wants to say
Right?
something.
Yeah.
Avoid eye
Yes,
trauma.
Dr. Amit.
Yeah, I just want to add, out of all the causes of angiostrix, which the PEPC, which you see, pseudoxanthoma elasticum, Ehlers-Danlos, Pages, pseudoxanthoma elasticum is the most severe form. The incidence is almost actually 80 to 90% patients develop angiostrix sometime. CNVM sometime during their lifetime, and the bilateral incidence is also very high as compared to the other ones, which is very less.
Yeah,
So,
because one of the reason is that angiostrix formation also is the highest in pseudoxanthoma amongst, say, sickle cell or other conditions as well. So actually, this was one of the questions. Good, you brought it out. The next question here, Dr. Abhishek, is that so Dr. Amit mentioned about giving monthly brolucizumab doses. Now we know that from use of brolucizumab for wet AMD or PCV, that we can some people use it every 6 weekly, 2 monthly. What will be your regimen if you want to use a brolucizumab for patients with CNV, or say in this case here?
As we all know that we all are using in our clinical practice Bolisumab. In fact, we are marketing it like that. We inject it and we might have a disease-free interval for 3 months. No? That is what we are marketing it. We are not doing in the typical advice form of a loading dose, right? But in this case, as we can see in Dr. Amit's case, at the end of 1 month, there is still persistent subretinal fluid and there is activity. So in this case, I would inject, right?
At the end of 1 month itself, you will inject?
I mean, there is activity still there left in this case.
But knowing that the drug is going to work for at least 2 months, that's what my question is. So
Yeah, that is what.
After month, we also continue injecting.
So that is what I'm trying to say, that not all patients of brolucizumab have a disease-free interval of 3 months. That is what I'm trying to say.
Yes. So in this case, after the first injection, you will also continue injecting it the next month.
Yeah, because it was not all dry. Right?
No, that's okay. I'm just asking yes or no. Okay, fine. Now, Chittaranjan, what will be your practice pattern? I'm trying to bring out different practice patterns.
I got it.
No one has proven here.
So at 1 month, if it was dry, I would have not injected. That is what I'm trying to say.
Okay.
No. Even if not fully dry, even if some response is there, I will wait. I will not give after 1 month, particularly for brolucizumab, I'm telling, because as we all have discussed, it's 3 months. So I'll wait for maybe 1 month at least more.
So after at the end of 2 months, if there's no subretinal hemorrhage, there's still subretinal fluid is there, the patient's vision is improved, you will wait or observe?
Wait. You are telling that initially it was after 2 months, but yes, it is present, but it is less in comparison to what it was there initially.
That on OCT, SRF is still present, IRF is still present, there is no subretinal hemorrhage, patient's vision has improved. Will you treat or observe at the end of 2 months after the first injection?
Observe 1 more month.
Okay. And Dr. Apurva?
Yeah, I agree. Actually, at the time you can wait for brolucizumab is what is the advantage of it, because the effect keeps happening for almost 12 to 15, not 12 to 15, maybe 10 to 12 weeks. So if there is response and if it has not rebounded, then I will wait till almost 2.5 months. So what I do is 1 plus PRN. And what I mean by that is not that if there is residual fluid, I'll treat. If there is residual fluid at 1 month or 2 months, but it is a significant reduction from baseline, I will still wait because it's brolucizumab and I have.
further question to you is that at the end of 2 months, your fluid has reduced, it's still there. You will wait and you'll follow the
I
patient.
will call this at this point. I will call the patient after 2 weeks and not at the 1
And
month.
at the 2 weeks, still fluid is there, you will inject.
That's too much, yeah. Now,
Okay.
I don't.
What I'm trying to bring about for the audience here is that there are different treatment paradigms. We are not claiming here this is better than that.
So what to answer your question
yeah.
correctly and definitely, until there is a rebound, which I expect after 3 months, like a rebound, I mean, by it comes back and it's not on the downhill anymore. Yeah.
Okay. Got it. So just for the audience, what we are trying here is that since there are no protocols which are there for pralicizumab, no larger studies are done for cases beyond the wet AMD or our classical CNVs. What you saw here, Dr. Amit, using monthly pralicizumab, Dr. Chitranjan said that his limit is at 2 months and Dr. Apurva will still wait. You can also write in your comments what will you prefer and what different you would have done. Dr. Samiksha, if at all, can you share your screen again? I think.
Yeah.
So the next question I want to ask here, maybe to Dr. Chitranjan or Dr. Apurva or Dr. Abhishek, anyone can take this. Are there any OCD biomarkers to predict in the, say, the treatment eye? Dr. Amit mentioned the treatment, the other eye, the fellow eye also has 70% chance of CNV development. So in the fellow eye, do we have any OCD biomarkers which can predict the chance of a CNV formation? I think Dr. Samiksha, if you go to the fellow eye OCT, I'm not sure if there was already a CNVM there. Yeah, if you see here, already some elevations here, and the ellipsoid zone here, I'm not sure it's SRF or there's already a CNV com. We don't have an octa, right, for your case?
No, sir, no. Sir.
Okay. Yeah, any comments?
I suspect that there has been some fluid here in the nasal macula, which is why the photoreceptors are elongated. That kind of thickening of the outer retina shows that the photoreceptors have had some stress in the past. It's either some very thin sliver of fluid or some fluid which has gone away. So that those photoreceptors are not healthy. Or on the other hand, I'm not claiming to be prophetic about it. Like, or it could be that it is probably going to develop a CNVM. Either of the two.
If you look at the IR image as well, on the left eye. Okay, so this patient had, when was this? Yeah, go ahead, Dr. Samiksha.
Is the FFA suggestive of something? Like if you see.
So which is the early phase here? And because the later phase is already there is staining which is happening, right?
No, I'm not sure if your FFAs are sequenced correctly. That third image seems out of place.
Yeah.
Yes, I think this was the first image. Yeah.
1
second.
So if this was the first image, definitely there is a leak happening, right? So I'm not sure if you can go back to the OCT, if any other image of an OCT, because
you have an OCT through that.
This is very important to pick up an extrafoveal CNV early. So that gives you time in terms of treating it, and your fovea is spared and patient's vision is maintained. So this brings in another question to me. See, one question is that, or one thought is that treatment of extrafoveal CNV, which are away from the fovea, say 1000 microns away from the fovea, and CNV developing nasal to the optic disc. Which one will you treat, observe, or do a laser to it?
Okay.
Observe.
Extrafoveal CNV also you'll observe, Dr. Apurva?
Yeah. I'll observe extrafoveal CNV. What I would be curious about in, like, suppose this case where it is supranasal to the macula.
Yeah.
What I would observe in such cases would be that if a CNVM is there, then there is a fault line there, obviously, like a line of risk. So I will look for the progression of that streak towards the fovea, maybe. If the patient has symptoms, for example, if the patient has a superotemporal to the macula CNVM with some fluid, then the reading vision will be hampered. Like we all know, supratemporal to extrafoveal CNVs have reading difficulties for the patient because it serves the inferonasal field of vision. In those cases, patient will have complaints, will have metamorphopsia, will have scotoma when he's reading speed will be reduced. Such cases I will treat. But this lesion which serves the inferotemporal field of vision, I will observe. But if the patient is symptomatic, I will treat. Nasal to the disc, I'll observe.
So
Okay.
what if these bleed, like if there is subretinal heme nasally? Like, because all these angioid streaks are starting nasally.
So that is what Dr. Apura mentions, that nasally she'll observe, but extrafoveally, if it's, I'm not sure of her answer. Sometimes she, at one point she said she'll be treating, at one point she'll say she'll observe.
No, that depends on the location, I said.
No,
No,
I'm talking about extrafoveal CNV within the arcade. Say temporal to the
yeah, so, correct. So if it is like superotemporal to the macula, it will serve the reading vision of that patient, inferonasal field of the patient. They will be symptomatic, so I will treat them.
So what about
That's what I said.
nasal to the fovea?
Yeah, again, if they're symptomatic, I will treat.
Okay, so if there's
And it is a
she'll treat.
fault. If it's a fault line, so
Got
if
it,
it's
yeah.
not symptomatic, then I'll observe.
Dr. Abhishek, what are your views on this aspect?
I will go with Apurva.
Okay.
Just simple.
Okay, and Dr. Chittaranjan?
Yes, agree with Apurva. Nice. See, it's very simple. If it is extrafocal, patient is asymptomatic, observe, but more closely. Like we should not just leave the patient like that.
So,
We should observe more closely. That's.
don't you think? Don't all of you think that the extrafoveal CNV, which is supranasal or supratemporal to the fovea, can actually migrate, or the CNV complex can migrate towards the fovea? That is my question to you.
Yeah, like I said, it's a fault line.
Okay.
Kabhi bhi ho sakta hai na. So I'll observe the patient frequently. Symptomatic patient, I will definitely treat.
How frequently?
Maybe monthly also. And home amslers. I'll tell the patient to monitor their near vision with an amsler chart for sure.
Okay.
Are these RP mottling suggestive of something? Like if we see in the right eye also.
PUD orange.
Yeah.
It's purely orange.
PUD orange.
Amit presented in his photographs as well.
So are there,
Amit
is there any
presented.
significance of these?
That's the appearance of the RP suggesting a Brooks membrane brittleness. The Brooks membrane is very brittle because of calcification. So that's why it looks like that.
So like further CNV can happen
that is the
over there also?
predisposing. Not like that. It predisposes to streaks, and streaks predispose to CNV.
So, Dr. Amit, in your case, are you there, Dr. Amit?
Yeah, I'm there. My video is not working.
Okay,
so
okay. After the third injection, how is the response now?
Actually, injection was given 2 days ago.
Okay,
So
after the second
waiting.
injection, the response, like,
Yes,
what was
yes.
any particular reason to go at a third injection right now?
Yeah, actually, that's what I just wanted to point out. So you are asking how do you go about? So again, for brolucizumab, even my treatment choice depends on so many things. Affordability of the patient. And this case particularly, I wanted to give an initial aggressive treatment for the initial 3 months. That's why I have chosen for like 3 monthly, and also it depends on the affordability of the patient. Actually, the patient was able to afford, and so okay, I thought I'll go ahead. So it doesn't happen with other patients. Most of the patients will be PRN only, even in my practice also. But this particular patient, I had gone ahead considering he was able to afford, and also I wanted to see the initial thing in the vision of actually 6-9 presentation. So I didn't want him to lose further. Wanted him to maintain the vision because sometimes, so initial aggressive treatment I have chosen for this particular patient.
Okay, so I think we had an interesting session here, and we are coming close to the session of our season 2, episode 1 of Late Night Retina. So just summarize from the second case what we learned. Important aspects about angiostric CNV is that treat them aggressively and have a close follow-up. Counsel the patient about multiple need for multiple injections, other eye having a higher chance of injections and treatment as well. From the first case, from the inflammatory, we had an interesting discussion about the etiology itself, whether it was mutes or it was a PIC with CNV. So important concept of choriocapillaritis came into the picture. Apart from that, we discussed about tuberculosis, sarcoidosis, and toxoplasmosis as other causes, important causes of CNVs in India. And we also discussed about role of steroids in the management of CNV along with anti-VEGFs. Any other final comments from any of the panelists? Okay, thank you so much, Dr. Apu, Dr. Chitranjan, Dr. Abhishek.
Well summarized. Congratulations, Dr. Rohit.
Thank you.
Thank
Dr.
you, thank you.
Avnish,
Thank you, everyone, and thank you. Congratulations to all the presenters.
yes, a big thank you, Dr. Samiksha, Dr. Amit, and Dr. Bhavani for joining us and giving us wonderful insights and sharing your cases. So once again, we are all here to learn. It's not about the right or wrong. We are all here to learn about this interesting findings. Dr. Avnish?
Yeah, thank you so much, everyone, the panelists, the moderators, as well as the presenters. And we would want to have more what we call submissions for our more coming up sessions. So please do send me your presentations, and it will be basically initial the CNVM patient cases would be discussed in the next 3 to 4 episodes. So thank you, everyone, and good night. Thank you so much.
Yeah,
Thank you. Thanks to all the viewers, especially the viewers.
and the participants as well for their interesting
Definitely
questions.
viewers, yeah.
Yes.
And thank you.
Thank you
Thank
for
you.
coming
Thank
to
you.
this late night meeting. Thank you.
Thank you so much.